Ranjit, can we start the program?
Yes, ma'am. We are live on YouTube and started the recording also, ma'am. We can start, ma'am.
Apurva, over to you.
Yes, ma'am. So, good evening to all of you. I'm really very glad to invite and welcome you all to this new series, Confusion, Clarity, and Consensus. Now, the first topic of this, webinar is a very important topic, and which I think, because I'm from very small place, from a very background player, where infection still play a major role, and it's a major challenge for us to prevent the mortality and morbidity due to the infection. So I really thankful to Anju Soni ma'am to start this webinar with a very basic and very important topic, and that to speaker is none other than but our very own, our President Foxy, Dr. Tang sir, Jaideep Tang sir. So over to Anju ma'am to start the program.
Thank you, Apurva. Thank you for a great beginning. I would like to welcome all the dignitaries here, Dr. Jaideep Tang, Dr. Sanjay Gupte, Dr. Hema Divakar, Dr. Lakshmi Shrikande, and all my coordinators. Good afternoon, all the delegates who have joined. We are all aware that every woman in her lifetime suffers from at least one or more infections, and gynecological infections have a long-term impact on the reproductive performance. There is a definite link between infections in women and the obstetric outcomes. Even a very, very simple common infection like UTI or bacterial vaginosis can lead to complications like PRO, preterm delivery. Infections not only just affect women in her lifetime, but also subsequent generations. And some infections are common during pregnancy, and some otherwise are not innocuous, uncommon infections can have profound effect and detrimental effect. It is pertinent that as obstetrician and gynecologists, we should have a sound knowledge of infections as to improve the maternal and fetal neonatal outcomes. And learning about these infection prevention practices will go a long way in improving women's health and eradicating maternal morbidity and reducing mortality. The aim of this series is to disseminate knowledge by experts in various fields that we can prevent and improve the health of every woman. So I am privileged to invite chairpersons, Dr. Sanjay Gupta sir, past president Foxy, and he doesn't require any introduction. Dr. Hema Divakar, past president Foxy, and associated with Manyata and artist. Over to you to introduce our eminent speaker, Dr. Jaideep Tang sir.
Right. Thank you, Anjuji. Welcome all to this wonderful webinar series. And we have a great speaker today, none other than our Foxy president, Dr. Jaideep Tang. Dr. Jaideep Tang not only is a very eminent and erudite speaker, but he has a lot of laurels to its credit. He has been the AOFOG Secretary General. Then he has been the president of Mumbai Association of Obstetrics and Gynec Society. He has been the chairman he is the chairman in FIGO for the Safe Abortion Committee. He is the director of Pharma Easy, and most importantly, in Foxy, he has left a great mark by actually starting. He is the pioneer of digitalization of Foxy, right from its website to e-voting. Everything, in fact, the digitalization was, one may say, taught to Foxy by Dr. Jaideep. And today's topic that he's going to speak about is also vitally important. This is on septic shock, which causes a huge amount of morbidity and mortality and requires very urgent treatment when the patient presents with that. And with now digitalization and genetic tests, the diagnosis of various strains of sepsis can be done in a couple of hours, and there are so many new modalities of diagnosis. So I'm sure we are all looking forward to listening to Dr. Jaideep that what should be done in this situation when patient is in dire situation of septic shock. So let's welcoming and over to my co-chair, Dr. Hema Divakar, for taking it from here.
Thank you so much, Sanjay. Namaskar and welcome to everybody, and thanks to Anju Soni for having us here. And her series of Confusions to Clarity and Consensus, the CCC, fits in well with the 3 C's of our beloved president, Dr. Jaideep Tank, with the tagline of Jivana Sivritam, which I very much appreciate the full circle that we all have to come round connecting the dots. The topic for today is septic shock. I said, okay, I know what is septic shock. Deadly. I know the speaker is deadly for sure. And nemesis. Whenever this Jaideep Tank, the think tank, speak, he will use some words like that, which I always go back home and check in the dictionary. What does that mean? What is nemesis? Okay, that is something which is, which is a deadly enemy to the women herself or whoever is in septic shock. I gathered that much as a fresh bit of English knowledge today. So we will hear more from our very eminent, very eloquent and erudite speaker, our beloved president of Foxy, Dr. Jaideep Tank, on septic shock, the deadly nemesis. Over to you, Jaideep.
Thank you. Thank you very much, ma'am, for that very, very kind introduction. I'm just trying to share my screen. Yeah. No, I think this is the wrong thing I shared. Sorry. Just 1 second. I just bought a new monitor. I'm still getting used to it. Right. I hope you can see my slide. It's the first slide. It's the flyer of the program. And I hope that I'm adequately audible.
Yes.
Thank you very much. So let me begin first by thanking the convener of this series, Confusion, Clarity, Consensus, Dr. Anju Soni. I worked with Dr. Anju Soni for a very long time in her tenure as chair of the HIV committee. And the work that she did as the chair of the HIV committee was quite exemplar. And it's a pleasure working with her. She's very pleasant, very nice, very knowledgeable, and very efficient. So thank you very much, Anjuji, for having me here. It is, of course, a pleasure and a privilege to be introduced by 2 icons of Foxy, Dr. Gupte sir and Dr. Hema Divakar ma'am. I look up to them a lot, and I learn from them every time I meet them, every time I talk to them. I think the gravitas which Gupte sir and his wisdom has served Foxy so well. And sir, both of you are past presidents, but you will never be past for Foxy, because Foxy will always keep on needing your wisdom and your services. And of course, Hema madam I think she's best known for Manyata, but actually she should be known for so many more things. It's just that she does so much that it's difficult to say that she's, this is the one thing that she is known most for. She's, a dynamo. I've called her the project lady of Foxy several times in the past, and she really has this uncanny knack of getting projects, delivering and executing projects. So thank you very much, ma'am. There have been a lot of lessons learned from this ability of yours. I'm also happy to see Dr. Lakshmi Srikhande, ma'am, who's just finished a brilliant tenure as the chair of the Indian College. And of course, thank the coordinators, Pratik, Indranil, and Dr. Sweetie, and Apurva over here. Thank you for conducting this webinar. When you become the Foxy president, it generally starts from selecting a theme for the year. And I know that Dr. Divakar has already spoken a little bit about the theme. You generally reveal the theme, if I may say so, in the September Managing Committee meeting of the previous year. And that's why last year in September, I had revealed the theme for this year. And again, I think, and I don't, it's important for me to say this all the time, that we are used to calling it my year, my team, my year, and every president refers to it. It's become such a habit. But I think I really want to reiterate that this is not my team or my year. This is Foxy's team. This is Foxy's year, and I just happen to be president. In any case, I'm very happy to share the theme of the year with you. And this is what the theme and the logo of the year looks like. And I have always believed that every logo and every theme should tell a story. What is before you should have a deeper meaning, and it should have some kind of a resonance for it to, percolate down and then take shape in the form of that given Foxy year. I'm very happy also to share that this entire concept, art, and design has been done by me personally. There's not been a single creative person involved in designing this. I have made it, if you will believe it, on PowerPoint. And I'm very happy that, a lot of people seem to have appreciated it and have liked the thoughts behind the theme. So having said that, let me, at the beginning, talk a little bit about the thoughts and the story, if I may say so, of this theme and logo. I have kept Foxy at the center because Foxy is and should be at the center of everything that we do as Foxians. I've selected the ring around Foxy in the form of many colors, and these diverse colors come together in the circle to create harmony and balance. And so colors in the circle also represent diversity, because I think that there is so much diversity in the people we serve, in the providers and the members of Foxy, in the services we provide, and all these ultimately blend together in a harmonious and a balanced whole. This circle is deliberately left incomplete. It's left incomplete to represent the distance that we have to travel to provide the best services to everyone who needs them. And it should be our aspiration in this year and the years beyond to complete this circle. And that's why that space is there in the circle. It's not been drawn completely. Foxy 360 indicates a 360-degree approach to women's health and to the institution of Foxy. Sometimes, we become so invested in ourselves and the way we do things. We don't realize that there could be possibly, it's not that we are doing anything bad, but it could be possible that there could be better ways of doing things which could benefit many more Foxians. I selected coordinate, communicate, and community because I believe that in this whole issue of narratives, and I will be speaking about that in the next slide, we have fallen a little behind. We hope that we want to coordinate by communication and develop a sense of community to present our point of view and set narratives from our perspective, because I feel we are reacting to narratives which have been set by others rather than setting our own narrative. I selected the color orange there because orange combines the energy of red and the happiness of yellow. As Kandinsky said, orange is red brought nearer to humanity by yellow, and it represents fire and it represents purity. And finally, and Dr. Hema Divakar alluded to this, I decided to use Sanskrit as the tagline. And the reason I did that was actually that language in India is a very, very emotive subject. Remember, when we got independence in 1947, our states were not made on the basis of ethnicity or demography. They were formed on the basis of language. And because language is so important in India and it's such an emotive subject, I thought I will have that tagline in Sanskrit, which is the mother language from which all languages have supposed to be evolved. And that's why I've used the words Jivanasya Ruttam, which means circle of life in Sanskrit. It's sort of closing the loop of having a circle, the Foxy logo in a circle, having an incomplete circle, and also referring to women's health as a circle of life, and rather than looking at it in various silos. So this is the theme of the year. I'm very, very pleased to acknowledge all the other office bearers of Foxy, all the committee chairs, and indeed each and every one of you, because we are all together Team Foxy. We may be having some post, or we may be holding some post, but actually what matters is the work which every single member of Foxy does on the ground to save lives. And before I begin talking about puerperal sepsis, let me try and set the context of what impacts our practice of obstetrics in this modern age. The way I have made this presentation is to first set the context in terms of how important puerperal sepsis is, give a little historical background about puerperal sepsis, talk about the settings in which puerperal sepsis can occur, and then go into actually the science of puerperal sepsis, septic shock, and then the management of septic shock, and finally end with talking a little bit about what Foxy means to me as both a president and a Foxian, and why I think we should all be very happy and proud that Foxy is doing as well as it should, standing as it does on the shoulders of giants. And I believe that, as I said earlier, narratives are crucial, really, when we think about the way we practice modern obstetrics. It's the narratives which are driving the way we are reacting and the way we are practicing modern obstetrics. Just think about the narratives which we are surrounded by. So there is this one set of narratives which comes, say, for example, from activists, policymakers, advocates for women's health, media, and so on and so forth. And an example of this narrative, and I am very consciously choosing the word narrative here because in a lot of instances, it is a narrative with not enough evidence to back it up. We are planning actually in this year to identify these narratives and validate or invalidate these narratives, which we will do in a series of sort of workshops, and then try and have some publications addressing these narratives. To give you an example, the narrative could be doctors do too many cesarean sections, doctors do too many hysterectomies, doctors do, charge too much for their services. And then, of course, there is this other set of narratives that we perhaps don't pay enough attention to, which is the narratives we share with our patients. Imagine you're sitting in your clinic and you have this patient and her relatives sitting in front of you. She's 32 weeks pregnant. She's got a ultrasound report with her, and you're reading the report. They're all sitting in front of you, and after reading the report, you tell the patient, well, there is a issue here. You have severe IUGR, severe oligoamnios, there are color Doppler changes, you have PIH, you have GDM, and the patients are looking at you very expectantly, and a lot of times what emerges from them is, but everything else is okay, no? And I always am rather astonished when this reaction comes, because I mean, inside you're thinking, isn't this enough? But obviously you cannot tell the patient that. And therefore, what you say is, yeah, everything else is okay. And then this creates a problem, because when things go wrong, and things invariably will go wrong in obstetrics, however good of an obstetrician you may be, the first thing which patients will ask you is that, doctor, till now you said everything was normal. Then now what has suddenly happened? And I think it is therefore high time that we start tinging our reassurances with a hint of reality. And I understand that it's a very, very thin and a difficult line to walk. You don't want patients scared throughout their pregnancy about what will happen in labor and delivery. But at the same time, you don't want them to be caught unawares when something goes wrong. It's like what Marston Wagner wrote in The Lancet, that nowhere is maternal mortality or perinatal mortality zero. And throughout history, women have accepted this harsh reality until recently, when doctors began to promise perfection. Now, when something goes wrong, women and families feel deceived and seek answers. And this exemplifies what I'm trying to say, that let's start tinging our reassurances with a hint of reality, making sure that we are conveying it in a way which does not make the patient scared or petrified about facing what will happen to her for the next 9 months. So having said this sort of context, let me now move on to maternal mortality. And, honestly speaking, I think sometimes we don't appreciate ourselves enough. If you look at the way maternal MMR is happening in our country, you'll see that we are currently at the lowest ever MMR in our recorded history. Admittedly, in the context of what that is happening in the world, we have a way to go. But I think at some point in time, we have to take a step back and say that, yes, things are not going too badly. In fact, if you look at it, we are now at 97, which is what the latest data shows. And within the context nationally, you will see that a lot of states have actually already achieved the MMR SDG target. In fact, it is now quite fair to say that we know where a large amount of our work should be focused on compared to where, it's not that we should take our foot on the pedal, but till where we can already say that we are doing very well. As far as the causes of maternal mortality go, and this is actually quite a revealing slide, if I may say so, because if you look at maternal deaths in India nationally, and you will see that 11.7% of them occur from sepsis. You look at Maharashtra, Tamil Nadu, and Kerala, states which have already achieved the MMR SDG, you'll see that the contribution of sepsis is 8.2%. And if you look at states in which the MMR is still very far away from the MMR, from the SDGs, you'll see that the incidence of sepsis nationally in the states which have achieved the SDG and in the states which are far away from the SDG is more or less the same, which obviously means that sepsis or septic shock in the times to come once, and I believe that the incidence of hemorrhage will strongly go down with introduction of heat stable carbetocin. Once the incidence or the contribution of hemorrhage falls, sepsis is quickly going to emerge as one of the problems which is going to be sticky and difficult to solve. And therefore, it's very important that we get a hold of this problem early and try and make sure that along with the reducing incidence of PPH, the incidence of sepsis also falls parallelly. But having said that, that is something which is easier said than done, because even in a tertiary health center in India, if you look at their data on women who were admitted, because of puerperal sepsis, you'll see that although the percentage incidence was only 2.5%, a large number of these women were referred cases. And when patients are referred, sometimes they are not referred early enough for a diagnosis to make a difference. And that was illustrated here, where surgical management was required in 75% cases, and 70% of the women succumbed to their illness, mostly due to multi-organ failure. And if you look at why these women develop puerperal sepsis in the first place, like a high incidence of PROM, frequent examinations, poor hygiene, you'll see that these are factors which can easily be addressed. If you ask me, one of the most important things is the delay in referral, which is actually responsible for a lot of sepsis taking a strong hold, going into multi-organ failure, from which it is very difficult to get patients back. So I think the first thing I would say in this talk is that if puerperal sepsis or a septic shock is suspected, refer early to a tertiary center where this can be managed easily. In fact, as Benjamin Franklin said, I can't think of a more apt medical situation to reiterate what he said about an ounce of prevention being worth a pound in cure. And this is something which any sepsis has taught us. If you look at all these pioneers in the field of sepsis and antisepsis, you'll see Ignaz Semmelweis showed that hand washing prior to delivery reduced puerperal fever. Ironically enough, at that time, Ignaz Semmelweis was ridiculed by the other, at that time, midwives, saying that you really think doctors are so careless that they would transmit infection and we would need to wear gloves or wash our hands. Ironically enough, Ignaz Semmelweis himself died of sepsis. He had a mental breakdown. He was admitted to a mental asylum in Vienna, and he ultimately died of sepsis. Quite an irony for the person who initiated our journey into controlling infection from any kind of procedures. In fact, Louis Pasteur then talked about bacteria and so on, and Joseph Lister introduced the use of carbolic acid as an antiseptic. And then Lawson Tate, in fact, a name which is not necessarily very much associated with asepsis and antisepsis, was actually responsible for shifting the movement from antisepsis to asepsis. For example, no talking policy, reducing the number of people, even operating uniforms, gloves, etc. All this was actually pioneered by William Halsted, and Bergman was the person who introduced the autoclave. So although, at that time, there was a debate about antisepsis versus asepsis, as Franklin said, prevention is better than cure. It is asepsis that we practice now rather than antisepsis. And of course, what really was a game changer was the introduction of antibiotics, an extraordinarily serendipitous kind of a discovery by Sir Alexander Fleming. He actually had told his lab assistant to wash some petri dishes. The lab assistant forgot to wash it. And when he came back the next day to actually shout maybe at the lab assistant for not doing his work, he found that the bacterial colonies around that, at that time, what was thought to be a fungus, had actually receded. And that's how antibiotics were discovered by Sir Alexander Fleming. And he wrote this very pithy sentence. He said, "I certainly didn't plan to revolutionize all medicine by discovering the world's first antibiotics," but that's exactly what he did. In fact, the first civilian to receive successful treatment with penicillin was Anne Miller in 1942. And incidentally, it was following a severe infection after a miscarriage. So in a way, obstetricians have a sort of a link to the discovery of antibiotics. Having said this context, let me move to situations in which prelude, septic shock can occur in obstetrics. It could occur after abortion. It could occur after birth, which could either be a vaginal birth or a cesarean birth. And of course, there could be sepsis during pregnancy. So let's address each by turn, and then we will bring all of it together in a general management of sepsis. So let me talk about maternal mortality due to unsafe abortion first, only to say that if you look at this chart, and if you remember the pie chart I showed you earlier, you'll realize that the maternal mortality from abortion is reducing dramatically. I'm sure all seniors over here who are senior enough will remember that every obstetric unit used to have two wards. It used to have the eclampsia ward, where patients with uncontrolled eclampsia used to be kept, and that ward typically used to be this very dark room, where patients were kept in isolation and so on. And they used to always have a ward for complications of unsafe abortion. And most of the times, the complication of unsafe abortion was in fact sepsis. These wards have completely disappeared. I mean, even when I was a resident, the abortion ward had completely gone. And this ward has completely gone because we now have such great and such safe methods of providing abortion. To illustrate, let me just show you this graph. And if you'll see this graph, you'll see that the contribution of unsafe abortion to maternal mortality when the SRS was done in 2001 was 18%. When this was repeated in 2003, 2004, they found that there was a surprisingly steep fall of 10% from the previous 3 years. And this is really the power of policy, isn't it? What happened in these 3 years to reduce abortion-related mortality so dramatically? 10 percentage points is a huge number. What happened was that in 2001, mifepristone and misoprostol came into the country legally and started being available freely. And although we talk a lot about the abuse of mifi and miso, I think we also have to consider the fact that availability of mifepristone and misoprostol has in large part been responsible. Consider the fact that at a community level, the choices of the woman who does not have access to abortion are either taking mifepristone and misoprostol in a way illegally, or going to, let's say, a dye and getting a stick put in her uterus. I remember vividly this video I had seen of a lady in Jharkhand, an illustrative video, who put a stick in the mud and then sat on the stick with the stick going into her vagina to provoke an abortion. And I don't think it would be fair for anyone to think that mifepristone and misoprostol taken in whichever form, in whichever way, in whichever dose is more dangerous than having a stick, vinegar, Coca-Cola, or acid put in the vagina to provoke an abortion. So abortion as a cause of puerperial sepsis or maternal sepsis is now on the downtrend. I'm not saying it doesn't occur. I'm sure it occurs even now, but is considerably on a downtrend. So before we proceed, it might be a good idea to understand the difference between infection, inflammation, and all the other terms. Infection is a microbial phenomenon characterized by an inflammatory response. Inflammation is the host response to the infection. I don't know whether all of you remember reading Bailey Love in 3rd MBBS, but it had that nice diagram of Todor, Color, Rudor, and so on and so forth, which were the signs of inflammation. So that's inflammation. And bacteremia is the presence of live bacteria. And septicemia as a term actually is outdated and imprecise and should be abandoned. The modern terminology should be sepsis, septic shock, and maternal sepsis. To put it simply, sepsis is defined as an infection plus systemic manifestations of infection. So you can have infection, and infection can ultimately cause sepsis. Severe sepsis is sepsis, which means infection, systemic manifestation, plus sepsis-induced organ dysfunction or tissue hypoperfusion. And septic shock is the persistence of hypoperfusion despite adequate fluid replacement therapy. So you can think of it either as a spectrum or as a continuum of events where it starts with infection, goes to bacteremia, sepsis, severe sepsis, and then finally septic shock. And therefore, the trick really is to catch it early at the stage of infection. So that's why an epiphany sepsis is not synonymous with either bacteremia or infection, but should be understood as a matter of organ dysfunction, which stems from a dysregulated host response to infection, and virtually any organ system can be affected. It's crucial to understand this because it gets rid of the notion that you need a classic picture of fever, etc., before you can make a diagnosis of sepsis. So if you look at the risk factors, they are very well known. And the reason why I have kept these two tables is that the table in blue are the risk factors in a country like India. And the one on table 1 is from the confidential inquiries into maternal deaths in a developed country. And if you look at both of them, you'll see that there are several commonalities across both the risk factors. So it doesn't matter in what kind of a resource setting you're working at, you still need to elucidate and look at the risk factors for puerperial sepsis. Before we go on then to the management of puerperial sepsis, let me present this really excellent study and something which we should strive very hard. And this is part of the project that we've got a grant for that we are going to talk about. And that is the use of azithromycin to prevent sepsis or death in women planning a vaginal birth. A similar study is ongoing for cesarean sections. And if you look at this, the simple measure of giving IV azithromycin, 500 milligrams, a single dose of IV azithromycin to all women who were planning a birth, considerably reduced maternal mortality from puerperial sepsis. And this is something, again, that we are going to talk more and more about as the year progresses and hope to introduce, particularly in low resource settings in the private and the public sector. Of course, there is this saying, know thy enemy, know thy friend, and so on. And if you want to know what is actually causing puerperial sepsis, you have to know the pathogens which are involved, because the way you plan antibiotic therapy will pretty much depend on that. So you have this whole group of gas, Streptococcus pyogenes, E. coli, Staph aureus, Strep pneumoniae, organisms which you would, in any other kind of a situation, tend not to take very seriously, but when they do cause infection, they can really be quite deadly. And then, of course, the dreaded MRSA, the Clostridia, and the Morganella morgani. So for diagnosis, as I said, is crucial that there has to be an early diagnosis, because disease progression may be rapid. The patient who seemed to be very well today with a mild infection and fever could suddenly become septic, because sepsis is not a matter of severity of infection. It's a matter of how the organs respond to the infection. And I would really like you to keep in mind this, because signs including pyrexia may not always be present and are not necessarily related to the severity of the sepsis. And it is very important to note that fever is not necessary or even sufficient to the diagnosis of sepsis. In fact, if you're suspecting sepsis, please don't use NSAIDs. It's a good idea to use any other form of antipyretic to control the fever, but don't use NSAIDs. And remember that the sepsis may not be arising only from the genital tract. There may be sepsis arising from outside the genital tract. So when you're looking at fever in the puerperium, or indeed in any part of pregnancy, you need to look at all these common infections like mastitis, something which is easily overlooked clinically, and something which I believe is taken a little lightly. You know, patients say, I've got engorged breasts and I've got a little bit of fever. You say, all right, you know, milk fever, it might be milk fever, just wait, it will settle down. You know, learning how to feed the baby takes time, and something which also brings me to another contention, that we seem to take breastfeeding as something which is natural, which every woman should do. But it's actually an art. And that's art needs to be taught, it needs to be inculcated. And again, that is something else that we're going to do in this year. So mastitis, don't forget to examine the breast, particularly when the patient has a symptom and when she has a fever. There could, of course, be urinary tract infections, and that's why we should try and avoid doing too much catheterizations during labor and delivery. It's the gram-negative bacterial infections which are particularly associated. And if the woman has a pyelonephritis, you need to be a little more aggressive and try and treat with higher antibiotics. Pneumonia is usually self-evident in terms of the fact that the patient has dyspnea, she has cough, she may have hemoptysis. Be as it may, if you are suspecting a pneumonia, an early diagnosis and consultation with a respiratory physician and a medical microbiologist is crucial. And finally, skin and soft tissue infection. I think one of the important things that you could do if you have a patient with fever in the puerperial period is take a look at the wound. The wound may either be an episiotomy wound, or it could be a wound of an abdominal delivery, but always open the wound and take a look at the wound properly. You should also not forget to look at the sites of IV cannulae. If you have drains, vascular access devices, and if it is possible to remove, you should remove them, because skin and soft tissue infections are particularly associated with toxic shock syndromes. And it's not, you know, very common, but if necrotizing fasciitis occurs, then it could really be quite a disaster, and the mortality and morbidity from this is extraordinarily high. This is not a case that you should manage in a small nursing home. These are all cases which you should manage in a large tertiary care hospital. Finally, don't forget the relatively less common causes of sepsis like gastroenteritis, pharyngitis, and infection related to regional anesthesia. Again, as you open the wound and you check for a patient who has fever, turn the patient on the back and look at the site where she's either been given a spinal or an epidural analgesia. If you feel that it is tender, it is red, and if the patient is complaining of pain at that site, don't hesitate to investigate accordingly. Of course, there is this whole conundrum of diagnosing sepsis with altered pregnancy physiology. In fact, in an earlier era, when the Swan-Ganz catheter was used, sepsis in a way, or organ dysfunction more particularly, perhaps was overdiagnosed, because a lot of the things which happen in pregnancy also happen in sepsis, which are reflected in the findings of the Swan-Ganz catheter. After all, most of what we consider as sepsis, or the thresholds of whatever we consider as sepsis, have typically been done in non-pregnant states and not so much in pregnant states. So there is a high false positive problem, but additionally, it's also the other way that the obstetrician may underreact to sepsis signals. So again, a high degree of suspicion, like what we say for an ectopic pregnancy, is crucial. What is helpful is the sequential organ failure assessment score. Any increase of more than 2 points above baseline identifies organ dysfunction. Now, on the one hand, we say early diagnosis, early referrals, but if you follow the whole SOFA score, you'll find that you need a lot of investigations into it. And because that time taken to get back the results of investigations and sort of act on them was considered to be a gap in early diagnosis. We came up with the quick SOFA score, which just takes into account respiratory rate, systolic blood pressure, and altered mental status. Obviously, the predictive value of the quick SOFA score is less than the full SOFA score, but it is easy to repeat and it is a bedside test which could already alert you before all the investigations come in. There is also this obstetrically modified SOFA score, which also evaluates 3 parameters and considers a score of 2 or 3 to be normal. Again, reiterating that fever, although it's often related to infection, it's neither sensitive nor specific in sepsis. And even the obstetrically modified SOFA score also has a quick SOFA score, which is quite similar. Instead of 22 there, it's 25 here, which takes into account the obstetric condition. If you have tentatively made a diagnosis of sepsis, even before you have arrived at the diagnosis with the help of blood tests, etc., you have to immediately initiate care, measure the lactate level, obtain blood culture, start with broad spectrum antibiotics, and begin rapid administration of crystalloid. The role of vasopressors has now come into some kind of a debate, particularly if the patient is responding to fluids. It's not necessary to give vasopressors all the time. And then after this R1 bundle, there are 3R resuscitation bundles and 6R resuscitation bundles, all of them having the same goal, which is to initiate antibiotics within the first hour of recognizing sepsis, maintaining CVP, MAP, SCVO2, normal lactate, and a urine output. If antibiotics are the mainstay of treatment, I think it's important to realize which antibiotic will work the best. The Infectious Disease Society of America convened a working group, and they offered both either monotherapy or combination therapy. And suggestions for monotherapy included 3rd to 5th generation cephalosporins, piperacillin, tazobactam, carbapenems. And if you're looking at combination therapy, then something which could also take care of a gram-negative coverage with an additional agent to cover gram-positive. And I think these are very, very sensible kind of recommendations. So if you look at the Royal College guidelines for the use of antibiotics, they are pretty similar with the addition of MRSA, where a glycopeptide needs to be added. Surprisingly enough, the WHO has got rather tepid kind of recommendations for puerperal sepsis. They say use ampicillin plus once daily gentamicin. I suspect this is because the WHO actually needs to look at various kind of resource settings. It's not that the WHO doesn't know that there are better antibiotics available. It simply is that the WHO has to cater to a diverse set of resource settings, and therefore need to make sure that whatever they recommend will be available in almost all places. So if you look at exactly your choices for antimicrobials, these are the pros and the cons, a SWOT analysis, so to say. So co-amoxiclav, which is used very commonly, doesn't cover MRSA, Pseudomonas, or EPSL. Metronidazole only covers anaerobes, and there are all these things which we need to look at. In practice, I think it's a good idea to perhaps combine metronidazole with either co-amoxiclav or perhaps piperacillin or gentamicin. It's typically metronidazole, gentamicin, and either piperacillin or carbapenem. IVIG does not need to be used always. It's usually used when the infection is very severe. Once you have started antibiotics, of course, you need to control the source of infection. And I think this is absolutely vital. You would hesitate to operate on anybody who has a septic shock because obviously your morbidity, etc., is going to be higher. However, till you don't evacuate the source of infection, for example, an abscess, for example, infected products of conception, you will probably not be able to control that infection. Remember that this is not a surgery to be taken lightly. Anybody who's operated on an infected patient will tell you that this is generally one of the most difficult surgeries that you will do, and I'll talk a little bit about that later. Fluid management, of course, is absolutely crucial, and point of care ultrasound is nowadays used to identify fluid responsiveness by measuring the diameter of the IVC. So if you have a nice normal diameter of the IVC, you know that she is replenished with adequate fluid. And of course, if you don't have point of care ultrasound, you can do passive leg raising to 45 degrees. It is difficult to do this when the patient is pregnant, but it is something which can be done when this point of care ultrasound is not available. Early goal-directed therapy has no place in contemporary management of sepsis in obstetric patients. The purpose of vasopressor is simply to constrict the pathologically dilated systemic circulation and maintain perfusion. So vasopressors should not be the first thing that you start. It should be antibiotic and fluid replenishment. And if she doesn't respond, then consider using vasopressors. And always, of course, all this has to be done in an ICU setting. I was talking about surgery in sepsis. It's always very difficult. It should be done in tertiary care. Please don't rush into it in under-resourced settings. It has to be a team approach with the standby of an ICU physician, adequate monitoring, proper anesthetic. And if you're going to do an uterine evacuation, please always do it under ultrasound guidance. Be very, very cautious because infected uterus is extraordinarily easy to perforate. And if you do perforate an infected uterus, you're going to have major trouble because the infection may escape into the peritoneal cavity. If you're suspecting a wound infection, don't hesitate to consult a general surgeon. They see so many more bad wounds than us. I know one of my friends is someone who looks after diabetic foot, and the kind of wounds that he looks after are really something which I'm always aghast to see. If at all it comes to a hysterectomy, always call for help. It's absolutely crucial. This is not going to be your routine hysterectomy. The tissue is going to be extraordinarily friable. Wherever you put the clamp is simply going to cut through and the patient will start bleeding. In these instances, it might be a good idea, therefore, not to apply the clamp. Tie it first on the specimen side, tie it first on this side, then apply the clamp, and then tie it one more time. Don't be in a hurry to finish this surgery, although there is the pressure of operating on a very serious patient. This is a surgery where you really need to take things slowly, very patiently, and very, very systematically. Remember that in these instances, it's typically the endometrium or the myometrium which is infected, chorioamnionitis, and so on. You need not do or don't try to go down too much and do a total hysterectomy. You can leave the cervix behind and then put in a drain to make sure that whatever remains behind gets drained out. Of course, in these cases, let's not forget the baby. The baby is also at risk of streptococcal and staphylococcal infection, and the umbilical area is actually of the baby is actually a good beacon, if I may say so, of identifying sepsis. If either the mother or baby is infected with invasive GIS in the postpartum, both should be treated with antibiotics. Also remember that long-term outcomes are always compromised, even in patients who have received adequate care for sepsis. And therefore, what is really crucial is to identify sepsis early rather than trying to make a diagnosis and then treating it. Finally, let me reiterate what Winston Churchill said, that when you have a patient with puerperal sepsis or a septic shock, you feel like you're going through hell. But the key thing to go through the whole thing and emerge victorious on the other side, as Churchill said, is if you're going through hell, keep going. That is what will ensure that the patient and you both survive this episode of puerperal sepsis. Thank you very much.
Thank you so much, Jaideep. If there is an opportunity for the audience to raise some questions, Anju can just tell us where to look for those questions. If
In oration, normally there are no questions, but still I can find out from.
Sure. Lakshmi, as the immediate past chair of ICOG, wants to raise some points, and Sanjay, of course, and then I'll go with few of my queries. Thank you so much, Jaideep, for a wonderful
crisp, informative talk, and I liked his last slide. Keep going through that. Jaideep is just superb presentation.
Thank you.
Yeah, I think very precise, very specific, always something that one looks forward to when Jaideep is speaking. There are not going to be any diversions, and it's going to be absolutely to the point, and it's considered all important points very, very precisely. I think, Jaideep, these are the kind of narratives that you're talking about that we have to convert into practices, and I think I'm sure you're looking at it, and you'll make it into something of a working practice for all the gynecologists and especially obstetricians out there. Very, very precise. I really appreciate that.
Thank you.
Jaideep, I have 3 little questions for you. One is that anemia being so common in our country, it is one of the predisposing comorbidities for rampant infection, and so is diabetes, with millions of them coming. None of our hysterectomy patients any longer are without any of these comorbidities. Something or the other is always existing. So do you think at the basic level, tackling these issues on a war footing will set the stage for a better management or reduction in the numbers of the sepsis that may arise in general?
Thank you, ma'am. And actually, I don't have anything much to add. You have already sort of put it so nicely that predisposing factors or risk factors, if you take care of, the chances that the patient will progress to a more severe condition will automatically reduce. And in fact, you have done such remarkable work on diabetes. You've led the WDF project for FOXY, and I think we can use that as an example, to take this forward. Most certainly, anemia. In fact, I was just a part of a meeting which were talking about something as simple as gastroesophageal reflux disease. And when I actually thought it through, I realized that GERD is not simply a troublesome symptom. It is also something which reduces compliance to nutritional supplements. And patients who have GERD don't take iron properly. And because they don't take iron properly, they remain anemic. And the incidence, I think it might be interesting to know what the incidence of anemia is in such patients vis-a-vis other patients, and whether patients with GERD should actually be considered to be a special group for early treatment with IVFCM. I was recently part, madam, of a group which from Anemia Mukh Bharat in the ministry. And what my contention there was that the threshold for giving IVFCM needs to be relooked at. Because anemia is in a way a progressive disease in pregnancy. You may say don't give IVFCM till she's below 10, but if she is 10 at 28 weeks, she's easily going to be below 10 by the time she becomes term. And when she really needs that hemoglobin, and by the time she becomes 10, it's too late to give IVFCM. So that's why we need to relook at the thresholds of administering IVFCM. This point was taken very well by the ministry. There was a hematologist, and he agreed with me when I said that by the time anemia manifests, you're already looking at severe iron deficiency. So what giving a dose of IVFCM will do is not only replenish or improve hemoglobin, it will also replenish the iron stores. And then if you give the 1.5 recommended dose, she's probably good to go with iron for almost a year. I think these guidelines will come out next month, madam. I mean, we've always been worried about giving IVFCM in pregnancy, but the Anemia Mukh Bharat already recommends IVFCM in pregnancy, and they're going to come out with guidelines on how to give IVFCM in pregnancy. So hopefully both these items will be captured.
Thank you, Jaideep, for raising this very, very important point about iron deficiency, anemia vis-a-vis iron deficiency itself. The thing is that we just have the access with point of care everywhere and anywhere just to check the hemoglobin, which is already a late manifestation of iron deficiency. Anemia. So if they're coming out
Yeah.
with a point of care for, say, ferritin estimation or iron deficiency estimation, okay, then we will have many more women who are already, brewing the iron deficiency, which is waiting to manifest as anemia. So it just because of lack of, this understanding on a general scale, the 10 gram% is ignored as it's kind of, it's okay. She may not lose her life, but each and every one of them do need the backup of the stores, as in giving the FCM. So I'm so glad that this point came up, and Anemia Mukta Bharat will be due for amendment very soon. And it's good for the organizations like ours to push it in a very much more stronger way, so that really it becomes Anemia Mukta. Sanjay, you wanted to say something?
I think this brings up a very important question, Jaideep, that what do we do when we know that there is likelihood of sepsis and the patient is anemic? Do we, use, IVFCM? Because, we published, as you know, the first paper in pregnancy anemia and, FCM. And what was found always was, if the CRP levels are on the higher side, or even, sometimes because of inflammation, the ferritin is, falsely high. And in that situation, if you end up giving, IV FCM, then one lands up with trouble, this thing. So here, already inflammation is there, not only inflammation, infection is there. So how would we give, if at all, IV FCM, or we should avoid that and go for maybe blood products in that situation, which again,
so I think I think there was some discussion on this, and in fact, there was some talk actually of using serum ferritin rather than hemoglobin as a marker for the use of IVFCM, saying that if you're, do serum ferritin, if your serum ferritin is normal, it's unlikely to be iron deficiency anemia, and look for other causes of anemia. The problem is that these Anemia Mukt Bharat guidelines are applicable for public sector also. And if they are going to be applicable for public sector, it's very difficult to say, do serum ferritin, because the turnaround time for serum ferritin in public sector is sometimes close to a week. So I think in any situations where there is any doubt about the administration of IVFCM clinically, it's a good idea to avoid giving. Sepsis would certainly be a good example of a condition where IVFCM should not be administered. But having said that, of course, these situations are few and far between compared to the incidence of iron deficiency anemia. And there will always be more situations where IVFCM will be required rather than situations where it won't be required.
True. Right. Thank you.
So, Jaideep, another question I had was, I'm full of questions. There's always accusation that we are using many more antibiotics rather than necessary, and being complacent that antibiotic so there should be anyway no sepsis, like we are safe, kind of multiple antibiotics, many instances which are not justified, and there's a huge lobby against unnecessary use of antibiotics, etc. So in this in this context, how could we, or did we, zero upon azithromycin as the one choice which we can universally promote as a prophylactic use, as how you had just said that Foxy would be taking that up through the year as one of its major initiatives?
So this was based on that trial which I showed you, reported in the New England Journal of Medicine. And it's actually interesting to think that how they must have arrived as azithromycin as a choice, although it's not very well elucidated in their paper as to why azithromycin. I would say the reason would be the kind of coverage which azithromycin has, and the kind of organisms which are responsible for puerperal sepsis are, fortunately in a way aligned. Secondly is the easy availability of azithromycin. And for me, what is a very, very important factor is the fact that azithromycin and anaphylaxis hardly ever go hand in hand. It's an extraordinarily safe antibiotic, where they say that if a patient has had anaphylaxis with, say, for example, monoseph or something of that sort with one of the cephalosporins, then your go-to antibiotic should be metronidazole or azithromycin. Because the incidence of anaphylaxis with either of them is extraordinarily low or almost non-existent. And I think these factors were probably taken into consideration before choosing azithromycin, and this was reflected in the serious adverse events which were reported in the trial.
Right.
So I think these are probably the reasons. I can't speak to as to what the authors had in mind, but I think these are plausible reasons for them to select azithromycin as an antibiotic of choice for prophylaxis.
Right.
It's also to do with cost,
Yeah.
because all the other antibiotics are relatively more expensive than azithromycin.
Sure.
Then would you, Jaideep, agree that in our country we should also look at azithromycin and metronidazole combination,
Yes,
because
sir.
because
Yeah,
cost
I
effective
would.
at the same time. Yeah, right.
Certainly, sir, a loading dose of maybe a gram of metronidazole along with azithromycin might be a better bet. But I suppose, we don't have the funding to do such a large study. Hopefully, you and Dr. Divakar will get us funding and then we'll do that study.
Sweetie wanted to ask something. Sweetie, you get us
No, it's okay. Yeah, it's okay.
Yeah, I just wanted to check with you. Does the study mention only the IV azithromycin? Is there any role of oral azithromycin that can be given?
So the study talks
Maybe
only
1
about
gram or
IV.
something.
No, study talks only about IV. It does not talk about oral. But I had done a study many years back when I was a honorary professor at Somaya Medical College, where we had, those kits which are available for vaginitis with,
Yes.
that fluconazole, azithromycin, and secronidazole. So we had replaced IV antibiotics with that. And we found that prophylaxis was equally good with this compared to, we didn't use only azithromycin, we used that whole kit. And we found that it was effective. The downside was a lot of nausea for the patients, particularly from the secronidazole. A lot of nausea and the metallic taste and so on. Yeah. But yeah, the study is not for oral at all. It's for a single IV 500 dose of azithromycin.
Anshu?
Yeah, what I was saying that I was going through various studies, and what I found out that in our country, I'm in any developing country per se, the rate of infections per se are much higher as compared to the developed countries because we have bad hand hygiene practices. So that is one thing which we must encourage throughout our practice, the hand hygiene.
Sure. Agreed. Absolutely agree. It's a simple procedure. It's a simple intervention, but can make a lot of difference.
So can we conclude?
Yes.
Yeah. So as we draw concluding our first of the series of webinars, I am compelled to take a moment to express our collective gratitude and admiration for the invaluable contribution made by all of you present here. The event has been not only been a beacon of knowledge, but also a testament of shared commitment towards advancing women healthcare. At the forefront of this commendation is Dr. Jaideep Tank, whose presidency in FOXY is commenced with a vision, leadership, dedication, and commitment. And it's I'm sure this his starting our series will be bring together, and he has brought in more data and evidence in this field to share his knowledge and insight. Has I'm sure enriched everybody in understanding the infections, sepsis in the gynecological care. And Dr. Jaideep, your initiative has set a high standard for all of us, making the beginning of what I am sure confident in transformative period for POXY also, and the broader medical community. The impact of this event extends beyond the immediate audience, as the knowledge dissemination here is undoubtedly enhance the quality of care provided to the woman and their family, echoing through the generations. I would like to extend my thanks to all the experts who have shared their experiences, and the organizing team for their tireless effort, and of course our attendees who have engaged with enthusiasm will make. I had so many phone calls to get the link. And in closing, let us carry forward the insights, inspiration gained from this series in future. And every Wednesday we'll be continuing with this 1 hour series with the leaders of leaders and masters in the field. I thank every one of you for making this event a milestone in continued journey towards excellence for the women healthcare. Thank you very much.
Thank you, Anjuji. Thank you. Thank you, sir. Thank you, Dr.
Thank
Divakar.
you.
Thank you,
Thank you
Lakshmi
so
Madam.
much. Namaskar.
Hearty
Bye-bye.
congratulations, Anjuji, for this first wonderful program.
Keep going.
Thank you.
Yes.
Thank you.
Thank you, Dr.
Thank
Thank
you.
you, Apurva.
Yeah.
Bye. Bye.
Thank
Thank you. Thank you,
Thank you,
Jaggi.
ma'am. Thank you, everyone, for participating this today's webinar and providing us with the opportunity to host this
Walter
event.
Bushner, thank you very much for being there. Always.
Thank you, ma'am. Thank you, ma'am.
Yeah.
Thank you, ma'am. So, ma'am, should I hang out?